And also like it helps like in socializing the patient also. He'll go, the person might get opportunity to interact with other people, or it could be helpful in, and it also sometimes dance is also helpful in improving the mood of the person. And cognitive behavioral therapy, if psychological therapy is used, it's usually used for like see patients with Parkinson's might because of the diagnosis of the disease, they might also suffer from anxiety, depression. So cognitive behavior therapy might help in targeting anxiety, depression. And sometimes the health psychologists see there will be a drastic change in their quality of life, and there will be a lot of changes, adjustments they'll have to make. So psychological therapy or counseling will help them to adjust much faster, but that can be a one sort of a help to the patients. Okay, so with this, we are finished with your Parkinson's. So today I am hope, because we have today and tomorrow. Just how many days are left? Today is first, isn't it? So just
Yes.
tomorrow is the last day.
Yeah.
Today I'm going to talk about childhood and adolescent disorders. Hopefully, I finish with this whole thing so that this just one lesson is left for tomorrow. Okay. So fast, I'm going to go. And unless and until it is really critical, don't ask me questions. I know it's very bad, but then I'm asking you of this because I have to finish. It's already 8:10. Okay. So childhood disorders. So disorders of childhood and adolescence. I'm going to cover this. Your lessons are split, but I'm going to do it. So abnormal functioning can occur at any time in our life. We all know about that. So children of all cultures typically experience at least some sort of behavioral or emotional problems, as sometimes they might encounter new situations, new people, and research has found that worry is a very common feature of childhood and adolescence. Okay, and other is like researchers also found the bedwetting, nightmares, temper tantrums, restlessness are also some of the problems experienced by many children. So adolescence can be a very difficult period. We all know teenage, so physical, because this is a very critical age where physical and sexual changes, social and academic pressures, so many things are collectively happening at this particular stage in life. During adolescence, like they have to try academic choices have to be made. So much of society pressure, especially related to academics, the ranks, admissions, and there are also physical changes, sexual changes are happening. And at this stage, children also, I mean, adolescents, they also go through personal doubts, self-doubts, and sometimes, because of the peer pressure, or sometimes they might get into wrong habits. And so temptation can cause many teenagers to feel anxious, depressed, confused also. And bullying is also, see, it's not just adolescents, during childhood also bullying takes place. So researchers found that over one quarter of students report being bullied frequently, and more than 70% have reported having been a victim of bullying at least once in their lifetime. So, disorders of childhood and adolescence. Some disorders of childhood, for example, anxiety, depression, they have adult counterparts. Okay, and other disorders of childhood, these are not covered in your lesson, but I'm just for your information. Other disorders like elimination disorders, for example, they disappear or radically change by adulthood. There are also disorders that begin in birth or childhood, and they persist in stable forms in adulthood. For example, autism, intellectual developmental disorder. So this is, see, previously we used to call mental retardation. Okay, so mental retardation is now being called as intellectual developmental disorder. So these are autism, intellectual developmental disorder. They persist. They are in the state, now from childhood to adulthood. So uh, now, what are the different types of disorders? So there are many, but I'm going according to your lesson, and your lesson talks about depression. So, major depressive disorder. So, around 2% of children and 9% of adolescents currently experience major depressive disorder, and as many as 20% of adolescents experience at least one depressive episode in their lifetime. So, see, you have to understand. So, while there is no difference between rates of depression in boys and girls before the age of 13, by the time age 16, girls are twice likely as boys to be depressed. Okay, so till age 13 there is no difference in the rates of depression equally, but after 13 years, basically around by the time they reach 16 years, girls have been found to have twice rate increases twice. Okay, so what are the factors? Why is it so? It has been suggested that it could be because of hormonal changes and increased stressors for the girls, and also increased emotional investment in social or other type of relationships. And also there is one crucial factor which has been identified, especially in current times, is that teenage girls are growing dissatisfied with their bodies. And I think it's a very serious issue because see, the media, movies, advertisement, everything is like talking about beauty, and coming up is this ideal body, ideal beauty. So that is creating doubts, and especially teenage girls, they start to feel dissatisfied with their bodies. So that can also lead to depression. So depression in the young may be children in the young may be triggered by negative. So what are the causes? In the young may be triggered by negative life events, especially if there has been some loss and major life changes, rejection, or abuse, which might be happening. So childhood depression is characterized by symptoms such as headaches, stomach pain, irritability, and a disinterest in toys or games. Clinical depression is much more common among teenagers than among young children. And suicidal thoughts and attempts are also common in teenagers. So now the next disorder is conduct disorder. So conduct, as many as 10% of children, that is three-quarters of them boys, qualify for this disorder of the conduct disorder. So children with conduct disorder, it is a very severe form of behavioral and emotional problem, severe problem. The symptoms are that they repeatedly violate the basic rights of others. They are aggressive, they are often aggressive and maybe physically cruel to people and animals. And they many steal from or threaten or harm their victims. And conduct disorder begins between age 7 and 15 years. Okay, 15 years. So it begins between 7 and 15 years of age. And what is the DSM-5 checklist? The criteria is one is, as I just mentioned, repetitive and persistent patterns of behavior in which the basic rights of others or major age appropriate social norms or rules are violated by them. At least now I'm going to give you a list. So at least three of the following features should be present, and the duration should be, 12 months. So these three of the symptoms should be present in the past 12 months. And if it is 6 months, then at least one of the following should be present. So what are those? Frequent bullying or threatening of others, frequent provoking of or frequent provoking of physical fights, using dangerous weapons, physical cruelty to people, physical cruelty to animals, stealing while confronting a victim, forcing someone into sexual activity, fire setting, deliberately destroying others' property, breaking into a house, building, or car, frequently lying, stealing items of non trivial value, that is, valuable items, without confronting a victim. So they will steal items, frequent staying out beyond curfews, beginning before the age of 13, running away from home overnight at least twice, frequent truancy from school, that is, running away from school, beginning before the age of 13. And because of these symptoms, there should be a significant impairment in terms of their social, academic, and family situations. There is one more symptom which has been found, and that is called as relational aggression. So, relational aggression is where individuals are socially isolated and primarily display social misdeeds. I'm sorry. And so, what is it that they will do? They will slander others. Okay, they'll spread uh, rumors about others. They will manipulate their friendships. And this relational aggression is common more in girls compared to boys. So, this is one more symptom of conduct disorder where they badmouth others, they will spread rumors about others, false rumors, and they will manipulate friendships. So, what are the causes of conduct disorder? So, many cases of conduct disorder have been linked to genetic and biological factors, drug abuse, poverty, traumatic events, and exposure to violent peers or community violence. So, if they belong to a group of friends who are already in criminal behavior or violent behavior, so they will also learn that. Okay, or if they belong to a particular community or a society or the place in which they live, which is like, prone to indulge in violent behavior or thieving or stealing, then these children might also learn that. So that is one of the causes. So they have most often been tied to troubled childhood. So conduct disorder has been very strongly linked with children having had a very troubled childhood, especially troubled parent-child relationships, inadequate parenting, if there is family conflict and marital conflict between the parents, and family hostility. Those family members are very hostile with each other. So, what is the treatment for conduct disorder? Treatments for conduct disorder are generally most effective with children younger than 13 years. And today's clinicians are increasingly combining several approaches while coming up with a treatment program. And so those approaches are sociocultural treatments, child-focused treatments, and prevention. So what are sociocultural treatments? They are family interventions where parent-child interaction therapy is, used. And so basically, parent-child interaction therapy especially targets communication patterns between parent and child, resolving conflicts. Okay, and parent management training also. So see, we believe the psychologists, and I don't. I mean, not. See, I firmly believe rather than we believe psychologists. I firmly believe that treat the parent and treat the child. So I believe if a child comes to you for it comes to you with complaints of behavioral issues, emotional disturbance. So I always believe the root cause, it's a pair, the parents. So if you are able to teach parents, uh, I think you will be able to so treat the parents, treat the children. That's what I believe in. So parent management training is where you teach techniques to parents. Okay. And second is residential treatment, where community-based treatments are offered. Then there are school programs, especially in Western countries. So, see, children with conduct disorders, okay, and as I was narrating the list, the symptoms of conduct disorders. So, a lot of criminal behaviors and and violent behavior is, you know, they indulge in criminal violent behavior. So many a times what will happen, they are caught by the authorities, by the law, and these children are sometimes placed in institutions, that is, and they are called as juvenile delinquents. So juvenile training centers, and these children are put in. So but then it has been found, that these children in juvenile homes or juvenile training centers has not met with much success. So in fact, it strengthens their kind of problems, it strengthens their juvenile delinquent behavior. And second type of treatment is child focused treatment. So focus is primarily on the child with conduct disorder under this approach. So, a lot of cognitive behavioral interventions are used, and we especially focus on problem solving skills. We teach problem solving skills to the child, where modeling of good behavior and practicing that behavior, role playing, and and reward system is set in, if they behave in an adaptive fashion. So there are systematic rewards which are given to these kids. So consequence, rewards and consequences. So basically, classic operant conditioning uh, principles are used. And then there is in the US, like there is a program called Anger Coping and Coping Power Program, and some of the clinicians in India also we also uses anger coping and coping power program. What it has children participate in group sessions that teach them to manage their anger more effectively, because anger is also one of the most uh, s- strong symptom of conduct disorder. Okay, and studies have indicated that these approach reduce aggressive behaviors, and also see conduct disorder children, they also indulge in substance abuse. So this program also prevents substance abuse in adolescents, especially and also drug abuse. So prevention is better than cure. So why? Because see, I think when I was talking about personality disorder, we were talking about antisocial personality disorder, and I had mentioned that every person, every adult who has been diagnosed as having antisocial personality disorder will have in their history during childhood conduct disorder. That is a compulsory thing. Every antisocial personality disorder will, if you take history, uh, you will find that they had conduct disorder symptoms during their childhood and adolescence. So so you have to understand this something very clearly. Every antisocial personality disorder will have conduct disorder in their history, but doesn't mean that every conduct disorder child will go on to become an antisocial personality. Okay. So what is it that stops? It's like, at a critical junction, at a crucial junction, if children with conduct disorder, if they are provided some help on time, some support, some treatment, then the life path changes. So not every child with conduct disorder will go on to become a criminal or an antisocial personality. So prevention is what we focus on for children with conduct disorders. So these prevention programs should begin in early childhood. So what these programs they try to do is change unfavorable social conditions before a conduct disorder is even able to develop. So such approaches work best if education is provided in the community, in the society, and also to the family members. Now the next disorder uh, for childhood is attention deficit hyperactivity disorder. So children who display attention deficit hyperactivity disorder have great difficulty attending to tasks. So problem with attention, behave overactively, that is hyperactivity, and impulsively. So there is children with ADHD, attention deficit hyperactive disorder, will have problems with attention, hyperactivity, and impulsivity. There are, previously, previously we, there are subcategories of ADHD. So one is predominantly inattentive type, predominantly hyperactive impulsive type, and combined type. So predominantly inattentive type would be the main symptoms would be of inattention, and hyperactivity or impulsivity will not be seen in that category. The second is predominantly hyperactive impulsive type. So inattention is not an issue. And third is combination. That is both the symptoms of inattentiveness, and hyperactivity. I'm sorry, hyperactive and impulsivity will be seen in the third type. So the primary symptoms of ADHD may feed into one another, but in many cases, one of the symptoms will stand out more than the other. So even if a child has both, like, I mean, all the three, like impulsivity, hyperactivity, and inattention, but you would find, if you, really observe these children, you would find that, there might be the other symptoms, but one of them would stand out more than the others. For example, in a child, he might or she might be having a hyperactivity, but inattention would be much more severe. Another child, inattention is not so severe, but hyperactivity would be much more severe. So about 4 to 9% of school children display ADHD. So as many as 70% of those 4 to 9% would be boys. So percentage boys more than the girls. So those whose parents have had ADHD are more likely than others to develop it. So genetic link is there. And the disorder usually persists throughout childhood, but many children show a lessening of symptoms. Symptoms will come down, a lessening of symptoms as they move into mid-adolescent period. And between 35 to 60% continue to have ADHD as adults. So about half the children with ADHD also have learning or communication problems, poor school performance, difficulty interacting with other children, misbehavior, often serious misbehavior is observed, and they will also suffer from mood or anxiety problems. So depression is also because of age ADHD. Children with ADHD will also suffer from depression, low self-esteem, because uh, in a school setting, just imagine, because of ADHD, symptoms of ADHD, child is not able to pay attention, child is not able to perform academically, and then he is targeted or labeled by the whole class. Okay, so that can lead to trigger depression, low self-esteem in the children. And how do you assess ADHD? We have different rating scales and diagnostic instruments to assess ADHD. And one very, very important thing which I really want to point out to you is, you cannot be over enthusiastic and diagnose a child as having ADHD. Uh, okay, there is one very crucial and critical criteria is, the symptoms of ADHD should be present across multiple settings, then only the child will meet the criteria for ADHD DSM-5 criteria. For example, the child might be hyperactive, inattentive at class or in the school, but at home he is very attentive, sits quietly and plays, and sits still. So those symptoms are not observed at home setting, then you cannot diagnose a child as having ADHD. So these symptoms should be present even at home, even at school, or if the child is at some other setting. So it has to be observed. These symptoms have to be persistent across multiple settings. Then only you can diagnose. So there are like many school teachers I have had in my experience. If a child is behaving you know, very in a hyper fashion or overactive, impulsive, or not paying attention, they are very over enthusiastic with labeling a child with ADHD. So and when we diagnose a child as having ADHD, we actually obtain reports of child symptom, not just from parents, from teachers also. So what are the diagnostic criteria for ADHD? Uh, so attention deficit hyperactivity disorder there are, as I told you, symptoms of inattention, symptoms of hyperactivity, and impulsivity should be present. So under the symptoms of inattention, I'm going to read out the list now. At least six of the symptoms of inattention should be present, and they should be persisting for at least 6 months to a degree that because of these symptoms, child is like there is impairment, like in terms of there is these symptoms are maladaptive and inconsistent with developmental level. Yeah, this is something which I forgot to mention. See, when we are talking about disorders of childhood, uh, you should first have firm understanding of what is normal development to actually understand abnormal development in children. Okay, so for example, a 2-year-old child, okay, and a 2-year-old child cannot sit still. If you expect a 2-year-old child, 3-year-old child to sit still, for half an hour, 15 minutes also not possible, and that is normal for that developmental level. Okay, and so you have to understand what is normal for what developmental level. You cannot call a 3-year-old child who it's not possible at all for that age to sit still for 15 minutes, and label that child that he is or she is hyperactive. And at the same time, 10-year-old child is expected to sit still at least for half. Okay, so you should have a firm understanding of what is normal development if you are like interested in really working in the field, especially child psychology. Okay, so according to DSM, at least six symptoms of inattention persisting for at least 6 months to a degree that is not consistent with normal developmental level. So what are those symptoms? Frequent failure to give close attention to details and making careless mistakes, frequent difficulty in sustaining attention, frequent failure to listen when spoken to directly, frequent failure to follow through on instructions and failure to finish tasks or work, difficulty organizing tasks and activities, avoidance of or dislike of and reluctance to engage in tasks that require sustained mental effort, frequent loss of items necessary for tasks or activities. So they'll keep losing things, pencil box, books, sometimes school bag, water bottle. But then again, find out what is the developmental level. Okay, 2, 3-year-old child, it's normal for a child of that age, 4-year-old child, to forget certain things. Easy distraction by irrelevant stimuli. So even if some sound is coming, they'll completely get distracted. Okay, forgetfulness in daily activities. And these are the symptoms of inattention. So at least six have to be present for at least 6 months. And at least six symptoms of hyperactivity and impulsivity, at least for 6 months. And those symptoms are fidgeting with or tapping of hands or feet or squirming in seat. They cannot sit still in seat. They'll come continuously do something with their hands or feet or move here and there in the seat. Frequent wandering from seat in classroom or similar situation. They'll get up and wander around, go around the classroom, even if teacher is taking class. Frequent running about or climbing excessively in situations in which it is inappropriate. Frequent difficulty playing or engaging in leisure activities quietly. Frequent on-the-go activity or acting as if there is some motor in there, driven by a motor inside their body. Frequent excessive talking, frequent blurting out of answers before questions have been. They will not wait for the turn. They will not wait for, they will not wait for the question to be completed. They will blurt out answers. Difficulty waiting turn. So they cannot wait for their turn. They cannot stand in line and wait for their turn. Okay, and these symptoms of inattention, hyperactivity or impulsivity, and the presence of these symptoms should be there before age 12, not after age 12. Okay, so suddenly occurring around age 12, then the problem is could be something else. The symptoms should be there, presence should be there before age 12. and symptoms should occur in at least two settings. Okay, so just because the child is being hyper or inattentive in school and not, very focused at home, and these symptoms are actually not observed at home, you cannot diagnose a child as having ADHD. At least two settings, the child should be showing these symptoms. And because of these symptoms, there is significant impairment in areas such as academic performance and peer, friends, social, basically, poor impairment in, socialization and at home. So, what are the cause? What are the cause of ADHD? So, researchers they consider ADHD to have several interacting causes. So, those interacting causes would be biological, psychological, and social. So biological causes, especially they have found that if there is an there is they have found that there is an abnormal dopamine activity. Dopamine is a neurotransmitter. There is abnormal dopamine activity and abnormalities in the frontal striatal regions of the brain of children with ADHD. So uh, there is problem with the chemistry, brain chemistry, and structural brain structure. And children with ADHD also, one of another cause is high levels of stress. So psychological cause. Then they've also found that children with one of another cause is family dysfunctioning. So these three causes might interact, and they say it could be interaction of these three causes might produce lead to ADHD. So about 80% of all children and adolescents with ADHD receive treatment. So there is, however, disagreement about the most effective. Clinicians, doctors, they don't agree. There is disagreement regarding the most effective treatment for ADHD. The most commonly applied therapy approaches are drug therapy, behavioral therapy, or a combination of these two. And millions of children all over the world and adults with ADHD are currently being treated with methylphenidate. You've heard about this? Its trade name is Ritalin. Heard about this name? Drug. So it is a stimulant drug that has been available for drugs and which is being prescribed for children with ADHD. So millions all over the world, children with ADHD, they are prescribed this drug. Many with ADHD, so as I told you,
Madam, will you please repeat the drug name?
Ritalin, Ritalin.
Okay, ma'am. Thank you.
It is a protected drug, and it's only given on prescription because it can be habit forming. So many children with ADHD are treated with Ritalin or other stimulant drugs. And as I told you, it is estimated that millions of children are given these drugs. Okay, so but many doctors, like clinicians, worry about the possible long-term effects of the drugs, and there are questions regarding the long-term effects, and there are also investigations in US that this ADHD is overdiagnosed in US. Like they are over enthusiastic in diagnosing children with ADHD. So as I mentioned to you right now, so to really work, to really understand abnormal behavior, first you have to understand normal behavior. If you don't know what is normal behavior, you will be over enthusiastic, going around calling normal children with normal developmental behavior as abnormal. And then another criteria is multiple settings. There should be consistency in terms of symptoms. You cannot just in one setting because the child is bored with the way you're taking class, or the class is not stimulatory enough for the child. He is bored, and then he is because of which he is inattentive or getting distracted. Or maybe you are making the child sit near the window where where near the window where he can see into the ground and can see so many kids playing. Okay, so obviously a child will get distracted. and the teacher might get over enthusiastic with diagnosing the child as having ADHD. So similarly, even psychiatrists, even doctors, sometimes they overdiagnose children with ADHD. But currently, Ritalin is still apparently very helpful for those who have been diagnosed with ADHD. So behavioral therapy is been used in many cases of ADHD. Parents and teachers, they learn how to apply. So here you are, teaching parents and teachers operant conditioning techniques to change the child's behavior. So operant conditioning would be rewards and consequences. So if a child is behaving, displaying a behavior, uh, the type of behavior which you want, then that behavior is rewarded. So any behavior which is rewarded, the child will tend to do it again and again. And if and there will be consequences. So if the child is showing inappropriate behavior and there are consequences, negative consequences, then the child will tend to decrease that behavior. So operant conditioning techniques are taught to parents and teachers in helping to change child's behavior. These treatments have been found to be helpful, especially when in combination with drug therapy. So now let's talk about autism. Okay. So there are two groups of disorders. As I was mentioning, when you're talking about children and adolescents, there are certain disorders which persist, such as anxiety and depression. They'll have adult counterpart, and then there are certain disorders which might remit or which might go away by the time the child is an adolescent or an adult. But and then there are certain disorders that emerge during childhood and they will continue unchanged throughout a person's life. And those disorders are autism spectrum disorders and intellectual developmental disorder. Autism spectrum disorders are a group of disorders which are marked by impaired social interactions, unusual communications, and inappropriate responses to stimuli in the environment. Inappropriate responses to stimuli in the environment is, for example, one example could be a child with autism, okay, and he will be like sitting or playing with whatever he is interested in, and so typically how we would behave, like if there is a sudden huge sound, like almost like a bomb blast is there, so all of us, like normal response would be we would get startled, isn't it? So child with autism might not even react to that such a huge loud sound, okay, and if and another in another direction, if there is a cooker whistle going on or somebody has rung the bell, the child with the child with autism would react so adversely, will so end up adversely, might start crying, and will react very adversely to that sound. So inappropriate response to stimuli in the environment is observed in children with autism. So autism spectrum disorder, or autism spectrum disorder was first identified in 1943, and children with this disorder are extremely unresponsive to others. So no social interaction. They, you know, almost, almost negligible social interaction, uncommunicative, and there is repetitive behavior, and they are very rigid. Symptoms will appear early in life before age 3, and around 80% of all cases appear in boys. So compared to girls, boys have been found to, the percentage is more in boys. So what is the DSM-5 checklist for autism spectrum disorder? Uh, Persistent deficits in social communication and social interaction, and featuring, I'm going to uh, read out the list, featuring all the following. Okay, deficit in social emotional reciprocity, that is like, if see, there will be no eye contact, Okay, so and social reciprocity would be like, see, when we smile at others, when somebody is smiling at us, we smile back. So that is not present. Eye contact will not be there. There will be deficit in no hugging. They don't like people to touch them. Okay, so deficit in non-verbal communicative behavior used for interaction. For example, you know, especially like, the speech is very poor in children with autism. So they will, if they want something, they might point out, or they will drag the person, or they will start to cry. Okay, deficits in developing and maintaining relationships, problems with developing, maintaining relationships. And there are restricted and repetitive patterns of behavior, interest, or activities featuring at least two of the following. So, stereotyped or repetitive speech, motor movements, or use of objects. So, the motor movements, like, sometimes they will just swing in the seat, in the chair, or they will very bizarre, repetitive stereotype. If they have a word, they'll continuously repeat that word. Excessive adherence to routine. They don't like change. So for them, routine is very, very important. Ritualized pattern of behavior or excessive, and they will react very adversely if there is change, okay, of environment, change of routine, and change of anything. They will not, adjust to. So, and they will react very, very adversely. Highly restricted, fixated, and abnormal interest are observed, and hyperactive or hypoactive responses to stimuli sensory input. As I mentioned, even a cooker whistle or a bell can, uh, they'll react very hyperactively. Or if there is a loud sound which you would expect the child to react, there will be no reaction at all. And the onset is by early adulthood, and these things will lead to significant impairment in terms of social, academic, all areas of life, basically occupational, all areas of life. Just a second. So as many as 90% of children that of children in as many as 90% of children, disorder will remain I'm sorry, as many as 90% of children, the disorder will remain significantly. The way I wrote, I don't know how. Disorder will, they will remain significantly disabled into adulthood. So even the highest functioning. So you might have seen movies or some, so this high functioning autism, okay, where like, so you might see that they will have some sort of you know ability, like mathematical ability. So that is some sort of ability. So even that higher functioning artist children with high functioning, even the high functioning adults with autism disorder will typically have problems in social interaction and communications, and they will have restricted interest in activities. And lack of responsiveness and social reciprocity is also one of the core feature. Language and communication problems take various forms, and one common speech peculiarity is echolalia. That is exactly echoing phrases spoken by others, exactly echoing what the other person is, the way the other person has spoken the phrase, exactly they will echo it in a similar fashion. Another is pronominal reversal or confusion of pronouns. So autism is also marked by limitative imaginative play and very repetitive and rigid behavior. So, if see, for example, like if you buy a car uh, to a child with, to any child, and the way the child will play with that car, like, he or she will be like, trying to ride, make it, try to ride the car or play with the car. Children with autism will not play it like, the other children, how they will play. So, the other children will try to, ride that car or take a car here and there. Children with autism, they'll be more interested in any lights coming from that car. So they will not show any interest in how to play with the car or a bus or whatever. If it's showing light or some sound, they will only focus on that. Okay. So this has been called as perseveration of sameness. And uh, you know, so they will play with, like, any shiny objects will especially attract them. And but again, the way they will play with that will not be how the other children typically play. Many sufferers become strongly attached to particular objects, especially, like, plastic lids, rubber bands, buttons, or water, and they may collect or carry or play with them constantly. And the motor movements of people with autism spectrum may also be unusual, often called self-stimulatory behavior. For example, like, it includes jumping, arms flapping, making faces, and also, like, different type of behavior, like, they will touch some surfaces, and will, and they'll touch the surface and try to feel it and then put their face there. So very self-stimulatory behavior is also observed. And children with autism spectrum disorder may also engage in self-injurious behavior. And sometimes they might seem overstimulated or understimulated by the environment. So previously we used to have different types under, so we used to call them as, the category used to be pervasive developmental disorders, under which we would have different categories. But now what they have changed that, and they've made it into uh, autism spectrum disorder. And we used to have a disorder called Asperger's disorder, but they have found that, it is not a different or distinct disorder from DSM. I'm sorry, from autism. And previously, who were diagnosed as having Asperger's now receive a diagnosis as autism spectrum disorder. So, what are the causes? Psychological causes would be, some theorists, they say that people with autism spectrum disorder have a central perceptual or cognitive disturbance. That is, individuals, they fail to develop a theory of mind. What is this theory of mind? It is an awareness that other people base their behaviors on their own beliefs, intentions, and other mental states, not on information they have no way of knowing. Okay. So it has been theorized that early biological problems prevent children from developing this proper cognitive development. And sociocultural causes would be, some clinical theorists have proposed, uh, just a second now. Some clinical theorists have proposed that a high degree of family dysfunction, social and environmental stress is also a factor in this disorder, but research does not support this theory. So now biological causes. Uh, so we have not yet come up with a detailed biological explanation for autism, but there have been some promising leads. Examination of relatives keep suggesting a genetic factor in the disorder. So prevalence rates are higher among siblings and highest among identical twins. Researchers have also identified specific biological abnormalities that can contribute to this disorder, especially abnormalities in the cerebellum. And previously, there used to be, now this theory has been not rejected. Previously, there was this theory, Bettelheim psychoanalytical theory. According to this theory, children develop autism because of rejecting an unresponsive parents. And because of rejecting an unresponsive parents, the child withdraws into his own world. But this theory has been rejected. So, So what are the treatment? Treatment can help people with autism spectrum disorder adapt better to their environment, although no known treatment totally reverses the autistic pattern. So you cannot reverse the pattern, but what you can do is teach them skills to better adapt to the environment. So treatments of particular help are cognitive behavior therapy, communication skills, training, parent training, and community integration. So, and also in addition, certain psychotropic drugs and certain vitamins have sometimes helped when combined with other approaches. So, I think it's almost going to be 9 o'clock, and doesn't make sense for me to start with intellectual developmental disorder, and because that is like previously called as mental retardation. So I have to, like, just so what are we left from your whole book is intellectual developmental disorder, and there is one lesson on adolescent disorder. Actually, in that they are talking about eating disorders and substance abuse. So eating disorders, substance abuse, and intellectual developmental disorder will cover tomorrow. Hope to God I'm able to cover. Okay, all of you.
Okay, ma'am.
Okay,
Thank you.
ma'am. Thank
Yeah,
you,
Thank you.
ma'am.
like we will be able to finish your portion
Yeah.
and we won't need any extra classes. Yeah,
Ah,
tell me.
no,
Somebody was asking me something.
nothing, ma'am.
Nothing. Okay, then. Just 1 minute is left. I don't think it doesn't make any sense to start also and getting cut midway. So tomorrow we'll cover intellectual development disorder, eating disorders, and substance abuse related
Okay,
to
ma'am.
adolescents. Substance abuse will not be covered as substance abuse is a separate category in itself. And when we talk about substance abuse, we are actually talking about like different classes of drugs and substances, and especially pertaining to adults and adolescents. But in your lesson, they're only focusing on adolescents, and very briefly they have covered it. So we will do that only. Okay then. Uh,
Thank you, ma'am.
Okay, ma'am. Thank you.
so autism have any? Okay, yeah. Most welcome. See you tomorrow then.
Okay, friends. Bye. See you tomorrow.
What is happening? They are not cutting me off. Can I continue with the lesson?
Are observing.
Hmm?
Will not cut.
Surprise. Let's see. Let's wait till 9:01. If they have not cutting me, then I'll continue with the lesson. What should we do? So, any idea what is? So yeah. What do you like understand when we talk about intellectual developmental disorder? Hmm? Anybody?